Welcome to Overtime with the Sports Docs. On each of these mini episodes, Catherine and I chat about a new topic or surgical technique in the field of sports medicine. We'll give you our quick take on the indications, various surgical approaches, and overview of the outcomes. Welcome back, everyone. We're really excited to be in the studio recording this episode to discuss distal biceps tendon ruptures and surgical repair.
On today's episode, we're going to chat about treatment of distal biceps tendon ruptures. We've seen this injury across many sports and in very prominent players. For example, Miguel Cabrera, all-star first baseman, sustained a biceps tendon rupture while at bat when he swung and missed an off-speed pitch. We also see this injury in CrossFit athletes, bodybuilders, and overhead laborers. This can be a devastating injury for our athletes. So understanding the treatment technique options, post-op rehab, and what return to sport looks like is super important.
So we'll start off with how to decide between non-op treatment and surgical repair and what those treatment protocols look like. Then we'll shift our focus to surgical treatment and compare 1 and 2 incision distal biceps tendon repair techniques. After surgical repair, there's then a decision of rehab protocols and returning people to play as well as to work.
We're going to reference many articles from AJSM throughout our talk today. We'll post the abstracts to our Instagram, which is the Sports Doc Pod. If you don't already follow us, you should. So if you're interested in reading more about the individual studies, you can find those there. All right, so let's jump into our discussion today, starting with treatment of acute, complete distal biceps tendon ruptures.
Distal biceps tendon ruptures are a relatively uncommon injury with a reported incidence of 0.9 to 1.8 per 100,000 people per year. The dominant arm is the most affected limb in the majority of cases, and males aged 30 to 50 years are the predominant population. In fact, I have never had a female patient with a distal biceps tendon rupture. Have you before, Catherine?
Never. Always a male. Always that demographic.
Always male. Absolutely. And I was talking to one of my partners about this, and he said in his entire career, he's had one female distal biceps tendon rupture, and it was in a professional bodybuilder. So kind of makes sense.
Yeah.
Yeah. So just to give us an idea of how male dominant this injury.
I know. I hadn't even thought about it until we were writing, and planning, but it's so true. Have never seen it, not in residency, training, anything.
Absolutely. It's always males, their 30s, 40s, 50s. And that are lifting something heavy.
Okay, so why does this occur? So the pathophysiology of the injury has been attributed to advancing age, hypovascularity of the tendon, and inflammation within the radial bursa that overlies that tendon. This injury generally occurs with an acute eccentric load on the tendon, basically an unexpected forcible extension of a flexed elbow.
When the distal biceps tendon detaches from the radial tuberosity, several surgical techniques have been described for repair. Traditionally, the surgery is performed through either a single or double incision approach. Reattachment techniques also vary. Fixation has been described via bone tunnel, suspensory fixation, suture anchors, and interference screws.
While surgical fixation has favorable outcomes for restoration of function and motion, complications are not uncommon. So complications might include heterotopic ossification or formation of bone in soft tissue where it does not belong, which can limit the elbow range of motion, particularly extension, tendon rupture or reeve rupture, wound infection, synostosis and nerve injury, specifically injury to the lateral antebrachial cutaneous nerve and the posterior interosseous nerve. So more on that later.
So first, we should discuss the initial selection of treatment. Do we ever manage this injury non-operatively? And if so, what is the population that we recommend non-operative care? So Catherine, what are your thoughts on this?
I have to say I've not managed one of these non-operatively, partly because I think the population that's coming to my office is a bit skewed. They're high demand people who want to get back to high demand activities. But I would say if someone came into the office that was very low demand, or maybe, if I was taking trauma call and this came across in someone who was very low demand, meaning, they're not doing, a lot of activity, maybe they're in the later stages of life, or perhaps they have some sort of illness that taking them to the OR is going to complicate their overall medical course. I think those are some categories that I would start to think about. And then also, smoking, I think, complicates this. But as we've talked before on this podcast, I don't tend to see smokers in Colorado, which is a nice thing. But yeah, I would say that there's definitely some people that I would say, no, this is probably not the best thing for you, but it has not come across my desk as of yet. What about you?
Yeah, I completely agree. I have not had one where I managed it non-operatively. Unless someone is extremely sedentary or has contraindications to surgical intervention, like you mentioned, I'm really recommending a repair. I think the biggest concern I have with this is that unlike issues like a rotator cuff tear or a meniscus tear, where you can try some non-operative treatment, and if they don't do well, then you can take them for a surgical repair with pretty much a minimal impact on their outcomes, their functional recovery, and their clinical outcomes, aside from a traumatic rotator cuff tear, but like a regular old rotator cuff tear. This, you have a narrow window to act, which we're going to talk about momentarily. So it's not like we can let this dysfunction declare itself. Someone all of a sudden notices that they're having weakness or issues, and then all of a sudden they're in the chronic category, and then it becomes a much tougher recovery and much tougher repair, and you may need to add an allograft or things like that. So I think unless someone really is sedentary and really is opposed to surgery or really has medical contraindications, I'm typically recommending a repair.
Yeah, fair. I think no different. And that's a good point. Like, you don't really have the luxury. Like, I use like the phrase luxury of time all the time when I'm speaking about certain diagnoses. Like, this is not going to change very quickly. It's pretty stable. You have the luxury of time to like do a little physical therapy and see if it goes well. Whereas like, this is definitely not that. All right. So now on to surgical treatment. So first, timing of surgery. Ideally, surgical management should be performed within the weeks of injury because delay in treatment makes things, ultimately a lot harder to get that retracted tendon, can, influence our surgical approach, and then, just overall make the whole process a lot more difficult. So Ashley, for you, how soon do you try and repair these? And then do you have a cutoff for, when it's chronic and you're going to plan for a more extensile approach?
Yeah, so I try to repair distal biceps tendon ruptures ASAP, like within the same week. COVID definitely made that very difficult in terms of getting people COVID tested and getting them in and things like that. But the sooner the better in terms of being able to easily reduce the tendon to the tuberosity. I'm sure you have had this experience too. You get in there in a couple of days, tendon just flops right into the surgical field. You get in there at the 3-week mark, and all of a sudden there's this abundant scar tissue that you're fighting through to try to get the tendon down. And I actually did a quick literature search on this to see if there was any link between amount of tension in the repair and failure rate, like we've seen for rotator cuff repair. There's nothing on this, but it just makes sense to me that having a nice tension-free repair where you can almost fully extend them at the end of the case is just better for a patient than this one where you're cranking them up to 90 degrees to get the tendon down because it's so retracted and scarred in because it's chronic. So I really do try to get to them as soon as possible. Beyond 3 weeks, I'm having in my back pocket a plan for an extensile approach to free up scar tissue, and also planning possible allograft augmentation, though thankfully I haven't had to do that for any of these cases.
Yeah. No, same. I think that 3-week, and even though there's not like, any big study that says that that's the number, I think that's the number we kind of get trained on and then stick with, and it really does change after that. So like you said, if you can get to it really quickly, that's awesome because the case is just a lot, it's a lot simpler. But not everybody presents right away. Sometimes it happens, they go to urgent care, and then urgent care says, okay, I don't know, let's go send you to a specialist. And then you get, getting an MRI, and all these things can delay by the time they actually get in front of you. And then you have to get surgical authorization. If it's workers' compensation, that takes even longer. So all these things can present delays. So I think ideal world, you get to it as soon as possible, just because it's easier on everybody. But, once you get to that 3-week mark, it does get a little bit more difficult. So same as you, think a little bit about the graft after that. Graft for me is only been in more of a chronic setting. And, someone who's had the injury known for a very long time, but, for their own reasons decided to not do surgery. Like they're trying to get through a job or, or maybe it was a financial reason for them, but, they sort of made a risk assessment for themselves.
Absolutely. So then once we decide to treat this surgically and we get the patient in as soon as possible, we then have to decide on our surgical approach. So that can broadly be subdivided into single incision technique and double incision technique. The single incision technique involves an incision over the biceps attachment site about 2 centimeters distal to the elbow crease. A plane is developed between the pronator teres muscle and the brachioradialis muscle. The 2 incision technique uses a smaller incision over the antecubital fossa and a second posterolateral elbow incision with a posterior interval developed between the ECU and the EDC.
A meta-analysis of single incision versus double incision surgical technique was published in 2016 in OJSM by Jones and colleagues at the Cleveland Clinic. This was a level 4 study reviewing the existing literature on treatment of the distal biceps ruptures, reporting single and double incision techniques. Frequencies of each complication as a percentage of total cases was calculated.
A total of 87 articles met inclusion criteria. Lateral antebrachial cutaneous nerve neuropraxia was the most common complication in the single incision group, occurring in 9.8% of cases. Heterotopic ossification was the most common complication in the double incision group, occurring in 7.2% of cases.
The authors found the overall frequency of reported complications was higher for single incision distal biceps repair than for double incision repair. The frequencies of re-rupture and nerve complications were both higher for single incision repairs, while the frequency of heterotopic ossification was higher for double incision repairs. So knowing all that, there's complications no matter what approach you take. And as far as how that affects your technique, do you change the technique at all based on, the patient that you're looking at? Do you have a discussion with them about these risks and let them weigh in on the approach, or do you just have a standard approach that you're most comfortable with?
So I found this paper really interesting because when they talk about the re-rupture, being higher in single incision, there's a lot of papers that show it's pretty equivalent. So I was wondering if maybe this was an older paper, they were looking at something else. The way I look at it, what I tell my patients is single incision has a higher risk of neuropraxia. I think because we're doing a larger dissection anteriorly and we're retracting, and that the posterior approach, or the 2 incision approach with the posterior incision has a higher risk of heterotopic ossification because you're really doing a lot more dissection there. I exclusively do single incision. I don't really change that based on the patient. In fact, if a patient said, I want a 2 incision, I would just send them to one of my partners who does 2 incision. There are a couple in my practice that do 2 incision because it's just not a technique that I'm as comfortable with. And I just feel like they'd be better served by someone who does that routinely. If someone has a certain body habitus or it's really retracted, I definitely will plan to possibly do an extensile approach to retrieve that tendon, or plan for allograft augmentation, but I'm still doing that single anterior incision to start. What about you?
Same. I'm doing single incision anterior. I also feel like when you're looking at those complications, if I, as a patient, I'm going to have a complication, I'd certainly, would prefer, injury to the lateral antebrachial cutaneous as opposed to heterotopic ossification or, a PIN injury. So I think, that's something that is a lot more livable. So as much as that risk might be percentage-wise in this paper slightly higher, we're talking about 7.2 versus 9.8. I still think it is, when you're weighing the type of complication, I'd rather have that complication. So I always stick with that approach. There's just a lot of counseling of saying, hey, this is a pretty, as surgeries go, this is in orthopedics, one of the ones that does have a higher complication rate, and, go through that all and just make sure that they have a really good understanding that even in, good hands and, really careful technique, that these things can still happen. So I think as long as they go in with that sort of expected possibility, then it's a little bit easier to deal with. And then as far as if it's retracted, instead of more extensile, we were talking about this recently, I'll go ahead, if it's retracted up into the biceps, make an additional incision at the level of that tear. So I will look at the MRI, get a sense of, okay, how many centimeters proximal is it, measure that all out in the OR, and then make my incision based on that.
Yeah, definitely. And I think you make a really good point talking about the different, the complications and the type of complication it is, but also what that complication is likely to progress to. So we know that nerve injuries, and I used air quotes. I know our listeners can't hear my air quotes, but nerve injuries are most likely neuropraxias. Even the PIN palsies from a single incision are likely from retractor placement. And it's interesting. I was actually talking to one of our mentors from the Harvard program, Tamara Rosenthal. She says that she's asked a lot to, she was talking about distal biceps repairs and PIN palsy a while back. We were talking about this, and she was saying she's been strong armed into exploring a lot of these because she's a hand surgeon. So she'll explore. And she's like, I've never seen the PIN not in continuity. Like, even when they do a bicortical button and it'll be sitting right next to the nerve, but the nerve itself is never injured. It's just been pressed by the retractor or stretched during retraction from the posterior approach. So those are going to get better on their own. I mean, PIN takes a long time to get better, but they will get better. The vast majority. I'd rather have that than HO that limits elbow motion. It's already a joint that's predisposed to get stiff. I'd rather not have that.
Yeah, agree. I think there's not a lot of options. And I did feel like anytime I saw HO as a physical therapist, it's really hard to get their full extension, and they might not ever get it. And maybe they stay somewhere like, at a loss of like 5 to 10 degrees, but that doesn't feel right, and it's just, yeah. So I think that's a complication that I just don't want to deal with for sure. So we're going to talk more about complications. Mm-hmm. All right. So
favorite topic.
Okay. So we have a systematic review to talk about. So complications after distal biceps tendon repair, published in AJSM in 2020. So the authors sought to report the rate of complications after repair of a complete distal biceps rupture and to classify surgical approach and fixation technique to analyze risk factors and outcomes of the individual complications.
So 72 articles encompassing a little over 3,000 primary distal biceps repairs were identified. The overall complication rate was 25%. So like Catherine was saying, this is not a procedure without its complications. The complication rate was split into major and minor complications. The major complication rate was 4.6% and included a 1.6% rate of posterior angioceus nerve injury, 1.4% rate of re-rupture, 0.3% rate of median nerve injury, and 0.1% rate of synostosis. Brachial artery injury, ulnar nerve injury, compartment syndrome, proximal radius fracture, and chronic regional pain syndrome occurred at a rate of 0.1% each. The majority of nerve injuries resolve with an expectant approach like we were talking about.
So minor complication rate was 20.4%. Most common complication was lateral antebrachial cutaneous nerve injury. So that was at 9.2%. An extensile single incision was associated with a higher rate of superficial radial nerve injury when compared to limited single incision. And limited anterior single incision technique had a higher rate of lateral antebrachial cutaneous nerve injury compared to extensile single incision. So that was 9.7 versus 5.2%, likely relating to the retraction. So synostosis occurred only with the double incision technique, and fixation had no significant effect on re-rupture rate and PIN injury rate, which I thought was really interesting.
Yeah, I thought that was interesting as well, too, especially given, we'll talk a little bit about, I want to hear how you fixate, but I fixate unicortically because I'm petrified of going bicortically and being on the other side by where the PIN is. And this is saying it doesn't make a difference no matter what fixation you use. So I did find that interesting. So this is the largest analysis of complications after distal biceps repair. So in summary, distal biceps repair has a major complication rate of 4.6%, which is pretty significant. This study was particularly helpful in understanding major and minor risks of each technique and appropriately counsel our patients. So we did talk about, do these complications change the approach we use? We both said no. We both use single incision. We just counsel our patients. What about surgical fixation? Are you using the same surgical fixation approach? What are you using? Do you change it based on the person's anatomy or other factors?
No, still So doing the single incision, as we discussed, also, as you just briefly said, unicortical, and had done button in the past, but more, I guess, over the last few years, probably at least 2 years, have just been doing all suture anchor. So onlay all suture anchor technique, which, part of the switch to that was I started doing that more proximally. And was really happy with it. And then the studies that had come out looking at like biomechanical equivalents, it's just a really nice technique as far as just feeling, again, you're not thinking about going bicortical, not worried as much if it, generally these are younger kind of males, so their bone quality and their bone density is going to be really good, but less worried about fracture. So I've been really happy with those. So tell me a little bit about what you're doing.
So I do a unicortical button. So I used to use the Arthrex proximal biceps tenodesis button, the 8mm cortical button, and that was a pain in the butt because it wasn't meant for the tiny proximal radius there. So I'm angling one way, I'm angling another way. Sometimes I would even have to go bicortical just to get the button into the intramedullary canal to give it enough room to flip. And I hated doing that. Then they came out, thankfully, after I complained incessantly to them, they came out with a smaller button, which now flips every time perfectly, never pulls out, don't have to drill bicortical. So I use that. I like the button because I get fluoroscopy and I confirm it's flipped. I confirm I'm at the area that I want to be at. Yeah. But I do like the suture anchor idea you have. I think the button, it's a 3.2mm drill hole, so the risk of fracture is lower. But I'm glad you brought that up because a lot of people are still doing the interference screw, which is a 7mm hole in the proximal radius. I mean, that just makes me too worried about fracture risk. So I do similar to you that it's unicortical and it's an onlay technique, but I just use the button.
Yeah, I think, and like you, I use fluoro. The only problem is like you can't, you're not even like you're not seeing did the button deploy or anything like that, obviously, because it's suture material. But I bring it in when I have my guide in place. So right before I drill, I make sure, okay, I'm really happy with where this is as far as the location, and then Alex, who I was talking about, is very skillful in bringing that fluoro in and out without moving my hand or, moving the guide. So basically, once I realize under fluoro, okay, I really like the guide placement, and then I just kind of go from there. So like you, I just, that extra sort of, let's make sure our positioning is, we're really happy with it. I think it helps.
Absolutely. And I think you made a really good point talking about fluoro at the start of the case to mark where it is. So I always do that because the last thing you want is to be off one way or the other. And then I put my little 3-2 drill bit right there and I get an x-ray to confirm before I drill because I feel like I can be tricked. I'm thinking I'm right in the center of the tube Rossi and it's actually along the edge one way or the other. So I always check that.
And I think, to minimize all these complications, you're trying to minimize your incision, so don't end up with like a superficial nerve or, vessel injury. But that also means that your incision has to be pretty spot on, so, and if you have a guy with a really big forearm, it's not exactly easy to palpate, exactly where it needs to be. So I think fluoro is super important.
I totally agree. Now, we talked about single incision versus double incision in terms of the risk of HO with a two-incision approach. Not really with single incision, but it does occur. Do you do any prophylaxis for reducing the risk of heterotopic ossification after this case?
I don't. Do you?
I do, but it's like I don't do the full, I know we were told the indomethacin 3 times daily for 6 weeks. That's a little overkill. There's some papers that talk about just doing 1 week can lower the risk. I do 3 weeks, which is the same that I do aspirin for DVT prophylaxis. I don't think there's a study looking at 3, but I do just to, I don't know, make myself feel better. And it's also good for pain control, but I have been doing that. I do 3 weeks, 25 milligrams, 3 times daily.
Yeah. And I think that, for the most part, it's going to be a healthy individual. There's really little downside to doing that. So, I definitely think that's something fair, something I might consider.
Yeah.
Okay, so let's move on to rehab. What were we going to say, Ashley? Were you going to say something?
No, I was going to say exactly that. Let's move on to rehab.
All right, so let's move on to rehab. So the primary concern following distal biceps repair is protection of the repair and caution to avoid over lengthening the tendon. So unfortunately, there is no major studies or trials on rehab at all. So I definitely start in a splint. And I usually just sort of say for two reasons. One, I just really want them locked up. I want them to be well protected, but I also want their incisions to be really well protected. It's something that when you transition, or if you transition to a hinge brace, which I do, I think it's very easy for those straps to sort of like rub on the fresh incision. It gets irritated. It can, sort of slow down the healing if it's getting a lot of friction. So I start with a posterior splint, and I just make it in the OR at the end of the case and keep them at 90 degrees. I also stick them in a splint. I always also stick them in a sling just for comfort.
Mm-hmm. Yeah, I'm very similar. I splint for about 7 to 10 days until their first post-op visit. Then I transition them to a hinged brace for 4 weeks. And then I think we do similar in terms of progressing motion. I do full flexion to 45 degrees of extension for 2 weeks. And then I advance 10 to 15 degrees per week with a goal of being full by 6 weeks. Though interestingly about the hinged brace, so we had a couple of insurances that just became a little bit nitpicky with what DME they were covering and what they weren't. And the hinged elbow brace out of pocket is like $275 or something bananas like that. So I had several patients where I did a quick search on this to find out if there was any literature, and there is literature saying you don't actually need the hinged elbow brace. And so for patients where they would have to pay out of pocket that amount of money, I just put them in a sling. And I just told them to come out frequently and do range of motion, but to use their other hand to block so they weren't going full extension, and just to kind of let PT be their guide. And they did great. So I still do the hinged elbow brace, but I'm wondering how much, like ACLs, I'm wondering how much we need it versus how much we do it to treat ourselves, Well,
I will say what we've done for some patients, and I'm sure that the brace companies don't like to hear this, is, same sort of thing where we know there's maybe an issue. They don't have DME coverage, or, and they're nervous about, not being in a hinge, or, just feeling like they can trust themselves, is you can really get the nice equivalent hinge brace on Amazon for about like $75. So
nice.
Or I think the other side of that too, of why I think it's helpful, is so when I was in fellowship, this person wasn't in a brace, but they were, they had a biceps tenodesis, proximal. And I think the story, it wasn't one of my patients, but I always remember the story and tell a lot of patients of it. I think the story was the patient was like coming out of the shower, and they had their phone, kind of in the, on their sink, and they basically picked it up with their non-surgical side, but since they were just out of the shower, they it slipped out of their hand, and they very reflexively reached and grabbed it with their post-operative side, and they were only a couple days out, so they basically just popped it, you know what I mean? So it's just, those are the kind of things where it's yes, you can give them the instructions and tell them to be good, but sometimes being locked in, it just protects you from the stuff that is just unexpected,
Absolutely. Definitely. Better safe than sorry.
Exactly.
So once we appropriately rehab our patients, then we have to talk about getting them back to work or getting them back to their sport. So the decision to return to work and to return to play must be individualized based on patient goals. At the 2019 AOSSM annual meeting, Dr. Verma and colleagues at Rush presented a poster entitled Return to Work and Sport After Distal Biceps Repair. They presented data from a prospectively maintained institutional database, which was retrospectively reviewed for all patients who underwent distal biceps repair since 2005 with a minimum of 24-month follow-up. A patient survey was conducted over the phone with regards to preoperative and postoperative participation in sports, level of intensity, and maximum weight repetitions of barbell and dumbbell biceps curls, bench press, and consecutive push-ups.
So a total of 49 patients were contacted for final follow-up information. Average age was 54, and the average time from initial injury to surgical intervention was 4 months. The dominant side was affected in 63% of cases. 32% of the injuries involved lifting of heavy objects, and 24% occurred during sport. Return to work was achieved in 86% of patients, occurring at an average of 1.4 months. Moderate and heavy duty status workers significantly differed from light and sedentary duty status workers in regard to average months to return to work. So it was about 3.7 months for laborers versus 0.5 months for non-laborers. The authors found that 73% of patients returned to the same or higher level of work. Return to sport was achieved in 90% of patients, and 45% returned to the same or higher intensity of sport.
Time from injury to surgical intervention was found to be significantly associated with decreased push-up counts and decreased days participating in sports per week postoperatively. So in some after surgical repair of distal biceps rupture, the majority of patients are able to return to work and sport. Those that work moderate and heavy duty status jobs tend to return at later dates, and patients with longer times to surgical intervention have worse functional outcomes with regards to push-ups and frequency of sports activities. So once athletes progress through the post-op rehab and they reach the end of their recovery, how are we determining that they're safe to go back to work, that they're safe to go back to sport? Is there anything you're looking for in particular when you're seeing these patients in clinic or talking to their physical therapist to make sure that they're optimized?
Yeah, I think, this was a really interesting presentation because there really is nothing out there. So this is the only thing that I know about that has at least some sort of sense of something you can kind of test for and look at how they're doing with push-ups and these types of activities. But, not everybody is like doing push-ups, it just sort of depends. So I don't think we have a lot of great tips and tricks to say, hey, here's the standard assessment. I think for me personally, it's really just trying to gauge, tell me about your job. What does your job do? Or what's your desired activity? Are you a climber? Are you just lifting for fun? Are you a CrossFit person? And really just trying to get them to understand that even if, say by, let's say 4 months out, I expect you're going to be able to sort of return to a lot of these activities. It's not like day one of that time period, you're like, okay, go to a full CrossFit workout. It's like, okay, this is the time when you're going to start to try this exercise or that exercise, but we have to build up strength and endurance. But yeah, I don't think there's any really great assessment. It's just trying to look at them as an individual. Unless, I don't know, do you have a really great assessment?
No, I don't. I think that's right. It's interesting. They do the return to work status assessment for the workers' comp patients, which kind of ties in what they do for work and make sure that they're safe and able to do those things. And so that's always really helpful to look at, but I don't do that routinely in everyone. I definitely, for when I'm thinking about disability paperwork, I'm usually doing 6 weeks for people who have sedentary desk work type jobs because they're in the splint and the sling and you can't drive when you're immobilized like that. But for laboring, I'm usually saying 12 weeks or 3 months, kind of, so I guess 12 to 14 weeks. And I haven't had a patient not be able to go back at that point. But it definitely is exactly what you said. You need to factor in what they do and make sure that they are okay to do that. And half the time I feel like it's hard for me to understand what my patients do with their jobs. Police officers, it's I'm filling out their sheet and it's can they fire off 50 rounds? I'm like, well, I've never fired a single round. So I don't know. You tell me, what do you feel, about your arm? Do you feel like it's strong enough? What do you need to get to be able to do those functions? So it's a lot of communication with patients, I feel a lot of the time.
Yeah, I think that it's definitely because it just varies in what their job is or what their sports asks of them. Like you said, if they're just working a desk job, this is much, easier for them to recover. But, if they're trying to do a certain amount of lifting overhead, it's just, really understanding not only what are you doing, how often are you doing it? And, and do you have somebody to sort of help you return gradually? Or do they expect day one back at work, you're able to do things fully? So I think those are just things we have to understand about that specific person.
Definitely.
Yeah.
Thank you for listening to our Overtime Chat. We hope you've enjoyed our conversation. Make sure to subscribe on iTunes, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback. your feedback. Perfect.
Great. Yep. All right. I'm going to stop it.
Awesome.
Yay. We did it.
I have a